All right, thanks to the organizers for asking me to present today. And I'll just start with my financial disclosures are listed here, none of which are relevant to this talk. And I'm presenting a case of a 58-year-old Caucasian woman who came in complaining that her left eye has been closed, and it closed several days ago. On talking to her, she's not a great historian, as many of our patients aren't. She thinks that there's been a few weeks of droopiness of her left upper eyelid, maybe even longer. She's not really sure. But it was really just mild droopiness, didn't really bother her. But over the last few days, the eyelid fairly suddenly closed, and she can't really open it. Maybe it opens a little bit in the morning, not most days. It's pretty much been closed all the time for 3 to 4 days. She does also endorse intermittent double vision when specifically asked about it. This is when she lifts her eyelid up. With the eyelid closed, she denies the double vision. She describes it as objects vertically or diagonally displaced, and it varies somewhat if she turns her head while she's trying to look and figure it out. She has a past medical history of hypertension, high cholesterol, and hypothyroidism. And she denies any other neurologic symptoms, no headaches, no head trauma, and no muscle weakness. Her examination shows good visual acuity, 20/20 in each eye, full visual fields, normal pressure, mild cataracts, and a normal fundus examination. But she has this complete ptosis of the left upper eyelid. Pupil exam shows no afferent pupillary defect. The left pupil is slightly larger than the right pupil. It appears to be about the same difference in terms of the size difference in both light and dark. And upon review of old photographs, there is a similar slight level of anisocoria present in old photographs. On alignment testing, she has a small left hypertropia in primary gaze that increases in down gaze and converts to a right hypertropia in up gaze, along with a small exotropia. So this is supposed to be 50-50, but my question to the audience gives you 4 choices. Do we think this is a compressive third nerve palsy, a vasculopathic third nerve palsy, myasthenia gravis, or thyroid-associated orbitopathy? If you can please vote. All right, vasculopathic third nerve palsy is most common, but there's some varying opinions. And with that, I'm going to turn over to the panel. If I can get the slides back. Whoops. Whoa. There we go. Panel. What do you think, and what do you want to do next? Anyone?
Well, I'll take a crack. So, to me, what's unusual for, it's obviously not a pupillary evolving third, for third nerve palsy is that the amount of ptosis is way out of proportion to the amount of ophthalmoplegia. In a partial or evolving third, you'd like to see a little more concordance in those findings. So that's what makes me less concerned about that, and I would look for other etiologies.
Well, I think you have to localize, right? So it's either third nerve palsy or it's not, or it's myasthenia. Okay? So we have those two. If you're even thinking it's a third nerve palsy, unless you are a real proponent of the ICE test showing you that her lid is going to salute and get completely better with ICE/rest for 15 minutes in the office, I think the problem here is even without the anisocoria, you worried about a third, because if you miss myasthenia, it's no big deal, right? She doesn't have any systemic symptoms, and it's not a disease you cure, it's only a disease you treat. But if you miss an aneurysmal third nerve palsy, you're in deep doo-doo.
I think it's hard clinically in this case, all other observations aside, that whether it's myasthenia or a third, because you have this history of the pupil being abnormal to begin with. So I would probably do both imaging, MRI angiogram, as well as send off for acetylcholine receptor antibody. plus or minus a SED rate in CRP to rule out giant cell arteritis.
So Grant, how rapidly would you obtain a vascular image? And would you go with an MRA, or would you go with a CTA, or would you go with whatever your emergency department can get for you within the next hour?
So if they showed up in the emergency room, it would be whatever I could get faster. We can get both at Penn pretty quickly. If it's an outpatient, I'd probably accept 1 to 3 days as an outpatient MRI angiogram.
So you'd let her go 3 days?
I would.
Oh, I wouldn't. So I would send this, if I wanted to spend 15 minutes and let her rest her eyes and see what happens to her lid, I might do that. I might do that as part of the process. But I would be sending this woman to have a CTA or whatever they can get from me that day in the emergency room.
Yeah, I think they, I don't want to go through all the rules of the pupil, but if the pupil were seriously involved, I would send her to the emergency room.
But it's a partial third. It's not a complete third with pupil sparing. The muscles
Well, the other
are-
question is, how long has she had that abnormality of the anisocoria? How old were the pictures that you were able to look at?
More than a year.
More than a year?
I don't care.
It's not, I don't think, the pupils at this stage of the game are not that helpful. And I'd like to know what's the reactivity, the size in dark versus bright illumination. But I think Nancy's right. I mean, you should check for myasthenia, do an ice test, do a rest test, see if there's curtaining, see if you have a Cogan's lid twitch on the other side, see if 15 minutes later the left hyper is a right hyper or the pattern has changed. I mean, that's the first and cheapest thing.
Even though I say that, I'm not sure I'd change my mind. I think I still would do a CTA on this person. And we have mostly general people out there, and I think the take-home message here is you don't futz around. You get this patient to have, I think, you have a vascular image. And despite the fact that it's been around for a while, I think every neuro-ophthalmologist in this room has the horror story of someone who has had a third nerve and the aneurysm ruptures in the elevator or in the waiting room while they're waiting to see the patient, and I don't want that to be me.
You had mentioned the ICE test. If you did an ICE test and the ptosis 100% went away, would you change your mind about imaging?
If the lid completely saluted and her double vision was gone, it would give me pause, and I might not send her to the emergency room, but I would be very uncomfortable. It's hard sitting up, well, actually, it's easy sitting up here in this kind of setting. It's hard when you're in your office and you have this situation, and I think times have changed. These vascular images, they don't hurt people. It's not like you're sending them for a digital subtraction angiogram.
I think the ICE test is too non-specific.
Yeah.
So I don't really hang my hat on that.
What's the time frame now? How far out are we from onset of symptoms?
So we're 3 to 4 days from the complete ptosis, and she had a vague recollection of maybe that eyelid was a little droopy before that, 4 weeks to months, not clear.
In my fellowship, I had one with 9 months. 9 months before an aneurysmal third was discovered, and part of the problem was she was treated with steroids and she got better because she was called Tolosa Hunt. And I don't think a response to steroids or the length of time it's been there helps you at all with that issue.
I agree 100% with Nancy. The paper that I'll quote later, when we looked at this in 2004, we looked at whether the duration of symptoms helped you differentiate between a microvascular cause and a non-microvascular cause, and the duration did not.
Let's go ahead and finish the case presentation and see what happened.
Okay, I will add some of the things you discussed. The ICE test was negative or at least inconclusive, maybe slight opening of the eyelid. There was no twitch. So the day of the presentation, we did get imaging, MRI and MRA, which was essentially unremarkable, no aneurysm. Acetylcholine antibody receptor testing was sent. We suspected a vasculopathic third nerve palsy, but still felt myasthenia was possible, as the panelists have discussed. Follow-up was scheduled, and the patient came back with little or no changes noted over the course of several weeks. She was paying attention to her eyelid and did report that perhaps her eyelid opens a little bit better in the mornings and then would be closed the rest of the day. Little or no change on examination other than slight variations in the amount of misalignment, but a similar pattern at every visit, both 4 and 8 weeks after presentation. And her acetylcholine receptor antibody was negative, so we ordered a single fiber EMG, and the EMG was positive. So this turned out to be ocular myasthenia with pyridostigmine and followed by prednisone started, and over the course of several weeks, the ptosis and diplopia improved. So I think the panel covered a lot of the issues that we wanted to discuss, but any comments on how this played out?
Probably would have ordered the single fiber even earlier. You mentioned that you waited until whether she had improved or not. I probably would have done, we typically, especially if the MRI angiogram is negative, receptor antibodies negative, while you're waiting to see what happens, we just go ahead and order the single fiber right away.
We had a common question from the audience regarding what the likelihood is of pain in an aneurysm and what you think about it in terms of this case.
Likelihood of what?
Of pain with an
Pain.
aneurysm. Shouldn't it have pain?
Doesn't matter.
Not
And
helpful.
as a matter of fact, you could take the opposite argument that vasculopathic third nerve palsies almost always do have pain, and it can be quite excruciating. So that can't help us. And Janet Rucker showed that with a paper she did on cranial nerves and pain. What I would talk about is acetylcholine receptor antibody positivity, because in the books, you'll see for strictly ocular myasthenia, they'll say it's about a 50% positivity. In my experience, it's more like 30 or 35%. It's very low when it's strictly ocular. But then Eric Eggenberger and his group showed that it could be as high, and Mike, as high as 70%. So it varies, but it's a very nice test if it's positive. It doesn't help you much if it's negative.
Let me ask the panel, what do you think about sending her to the ER for an IM prostigmine test?
I was going to ask the question whether any of my other panelists do IV tensilon test, which I used to do in the office.
Well, I used to do a lot, but we can't get it anymore.
Right, well, it's not available anymore, so it's
We
a
don't
moot point.
we don't do them anymore.
What about prostigmine?
We don't do them anymore.
Yeah. This would have been a perfect case for it. And when I was growing up, this was my prime type of case to do tensilon in the office, because a lid, you don't want to deal with the ocular motility, but when you give just the test dose of 2 milligrams of tensilon, the lid would go up and salute. I mean, it would just completely reverse, and then you stop. But I don't do it anymore.
We had another question from the audience, if you could address the lack of variability in the exam in a patient with myasthenia.
Well, I think it was variable. She had some long intermittent ptosis, and which had changed, and of course the diplopia is no longer variable after there's complete ptosis. But at one point, didn't she say it was vertical, and then but there's obviously a horizontal deviation too.
Happens.
She was relatively stable, but again, we do see this in myasthenia.
But I would go back. I think it's so characteristic of myasthenia to have the ptosis be so much more prominent than the ophthalmoplegia, or sometimes vice versa, particularly in kids.